Good evening to everyone present here with us today. This is Shriyan from IGCP, today's moderator. I would like to welcome all the viewers who have joined our platform for better exchange of knowledge that is going to be shared by your keynote speaker, Doctor, for today's session. With much pleasure and honor, I would like to welcome our very renowned Professor, Dr. Madhulata Alexander. Ma'am is Professor at Osmania Medical College, Hyderabad. With the help of ma'am and her wonderful insight, we will be taking a close look on today's topic, which is saving two lives, one beat at a time, cardiac disease in pregnancy from a physician lens. Now, without any further delay, let me welcome ma'am again at our forum and would like to hand over the session to her. Over to you, ma'am.
Yeah, thank you, Sriyan, for this kind introduction. I'll just share my. Okay. Yeah, thank you. I'll just begin my short presentation. The topic given to me was saving two lives, one beat at a time. Cardiac disease in pregnancy. Now, we know the fetus is an integral part of the mother. They both are linked together very intimately for the first 9 months. So you cannot really think of them as two different entities. They're actually only one. So that's why they beat one beat at a time. So I will be discussing today cardiac disease in pregnancy from an obstetrician's point of view. Now, when a patient comes to us in the OPD, she comes and asks us, she has many questions. Especially, we are talking about a woman who is having a heart disease. Now, heart disease can either be congenital or acquired. In India, the most common heart disease is acquired. It is the mitral stenosis, which is a sequelae of rheumatic fever. In the Western countries, the statistics are slightly different. Probably congenital heart disease is leading the show. Now, these women come to us, and it's about percentage is about 0.3 to 3.5% of all pregnant women are having heart disease. Now, she comes to you with these following questions. Can I become pregnant? Now, I suppose there's no right answer to this because this answer she has to deliver. She has to delve into herself and may come to conclusion. What we can do as obstetricians are we can guide her with facts, which I hope that will be a little more clear to us at the end of this lecture. Also, she wants to know what are the risks of pregnancy to her. What are the risks of pregnancy to my baby? And also nowadays, everyone's so perturbed. They all want to know their mode of delivery, their birth plan. She always wants to know, do I have to have a C-section or will I have a normal delivery because of my heart condition? And what are the chances that my baby will have congenital heart disease? This is probably a very important burning question for her. And also she wants to know, does pregnancy affect my long-term health? Now, all these questions will be running through her mind when she consults you. And preferably, she should consult you before she gets pregnant, before planning a pregnancy. Now, pregnancy can mask the symptoms of heart disease. I work in a public sector hospital. We have about 1,200 deliveries per month. And you can imagine the load of cases that we all handle in my hospital. Many women present with fatigue, shortness of breath, and pedal edema. These are also cardinal symptoms of cardiac disease. They can also be found in normal pregnancy. But if they are persistent and severe, it has to get investigated. In fact, every year, even now, we get patients whose heart disease is diagnosed for the first time when they're present in labor. Now, always the stenotic heart lesions are worse tolerated than the recurgitant. Recurgitant ones are better tolerated because of the decrease in systemic vascular resistance with help in their valves. The right heart, if you see the right heart lesions versus left heart, the right heart lesions do better. Now, what are the importance? What is the importance? Women with severe heart disease, they require early multidisciplinary consultations with the maternal fetal medicine unit, with the cardiologist, anesthesiologist, us obstetricians, and the pediatricians. The goal is to optimize cardiac function before conception to minimize pregnancy complications. Maternal mortality risk correlates with the New York Heart Association class, NYHA. My PGs are calling it the NYHA class. But the disease progression during pregnancy is unpredictable. When a patient comes to you, what is the first thing you do? You have to take a detailed history and physical examination, review recent ECG and echocardiogram. Nowadays, even stress test is added to this. Functional classification has to be done. Risk has to be categorized into low, intermediate, or high risk. What are the various risk factors for cardiovascular morbidity and mortality? The race plays a very important part, with African American women having the highest morbidity and mortality rates. Age. Women more than 40 years are having a higher risk of complications. Hypertension, which is so rampant. Chronic hypertension, gestational hypertension, and preeclampsia, they increase the cardiac burden and therefore these patients have problem in pregnancy. Obesity. We are finding more and more patients who are obese coming to our clinics, even in the public sector. Greater BMI, higher the risk of heart failure. So be careful. Thromboembolism and arrhythmias can occur more frequently in these morbid conditions. Socio-economic disparities also play an important role. Now, whenever a patient comes to us, it was necessary to classify a patient based on the functional classification of her heart by using the NYHA classification. We all are familiar with this, class 1, where there's no limitations of physical activity in the presence of cardiac disease, or class 4, where there is inability to perform any physical activity and there are symptoms of cardiac disease even at rest. Class 3 will also include paroxysmal nocturnal dyspnea, when the woman gets up in the night gasping for breath. That is not a good sign. Now, based on this, many risk prediction models have started. Every woman before pregnancy, she wants to know, what is the risk of me having any decompensation during pregnancy? What is the risk of me having a primary cardiac event? What about my baby? All these questions come to her. So there are many risk prediction models which have evolved. CarPreg 1 was having only 4 features, but now CarPreg 2 is got many more features. It's being more used. The other risk model is Zahara, which is used only for congenital heart disease risk assessment. But everyone now, including the cardiologist, likes this WHO risk classification system because it is a more comprehensive risk stratification model and it has been standardized. It predicts maternal morbidity and mortality. It assists in preconceptional counseling and pregnancy planning. CarPreg is what cardiac disease in pregnancy 2 scoring. These are all the scores. And once you go through them, you land up at a score. And this, depending on the points, gives you a prediction of the risk of primary cardiac event. More than 4 points, about 41%. So think before you get pregnant. Before you get pregnant, you have to think about it. Maybe you need some kind of modification or medication before you think of pregnancy. Zahara scoring, as I told you, there are also points given, but this is mainly for congenital heart disease. WHO classification is being used by all of us nowadays. WHO 1, which involves small or mild pulmonary stenosis, small PDA, mild mitral valve prolapse, or ASD, VSD, or PDA, which has been declared. But WHO 4, if you see, it requires pulmonary hypertension, severe MS, severe coarctation of aorta, and the Marfan disease with aorta diameters more than 45, history of peripartum cardiomyopathy automatically belongs, you go on to class 4. And also, if the ejection fraction is less than 30%, you go on to class 4. 2 and 3 are in between. And WHO 4, better to think before getting pregnant. And if you are pregnant, better to terminate the pregnancy. What about risk to the baby? This is very, very important. The mother is very, very anxious about this point. Mothers who have heart disease, there's increased risk of miscarriage, prematurity, low birth weight, and they also have congenital heart disease. Now, what are the factors that influence all these negative parts? Maternal rhythm. If the mother has any ectopic beats, more commonly atrial tachycardia, VTAC, all these are not good. Metal oxygen saturation, if it is less than 92, it is also not good. Metal tobacco use consistently. Tobacco use is not a good feature for most of the diseases. Maternal age more than 40 also has a direct list to the baby. Now, if a mother has a congenital heart disease, about 0.8% is general population risk. But if the mother has it, it has about 3 to 12% recurrent risk. And if the father has it, there's about 0.5 to 3%. And if they both have it, the percentage is not yet worked out, but maybe somewhere in between. Now, the risk of congenital heart disease in offspring of women with congenital heart disease, any defect is about 5 to 6 neonatal risk has. So ASD, VSD, tetralogy of Fallot, which is being corrected, we have seen quite a few cases. Transposition of great arteries. We currently have a patient in our hospital who is undergoing her second pregnancy. She is about 35 weeks now waiting for delivery. She has been advised by our cardiologist not to continue the pregnancy. She came early to us, but still she was insisting, and she is with us, and hopefully we'll give her a healthy baby, and she should also be okay. What about antenatal care? How do you deal with patients with heart disease? What about antenatal care? It's a multidisciplinary team approach. Clear counseling. You have to give the counseling. You have to give the risk, preferably to both the partners. Early risk assessment and monitoring. Use those scores. Actually, the patient can have some idea what to do. And for in case of class 3 and 4, you have to hospitalize the patient immediately. And in class 4, think of pregnancy termination. It should be given and offered to the patient as an option. Antenatal care every 2 weeks up to 30 weeks for all patients, then weekly. On each visit, you look for the pulse rate, BP, cough, breathlessness, weight, etc. Now, this is important because it shows the patient is going into failure. Re-evaluate functional gait every visit. And it's very important to do a fetal 2D echo. We do it in our hospital around 24 to 26 weeks because these patients also are having a higher risk of congenital heart disease. Hygiene and dental care to prevent any infection. Now, before we used to give a lot of infective endocarditis prophylaxis, but nowadays, for any procedure, when you're having a dental treatment, give this. But nowadays, the current concept is individualize each patient, give proper hygiene, dental care only if necessary, or if the patient had previous history of infective endocarditis, only then you're supposed to give it. Early diagnosis of any infections, treat PIH. One of the most important ways of management of these heart diseases is to restrict the activity because it affects of the patient, because it avoids tachycardia, therefore load on the heart, improves renal perfusion, reduces the metabolic needs of organs, especially skeletal muscles, and decreases the blood flow to resting muscles, therefore reducing cardiac overload. Dietary salt restriction is needed. Do not add extra salt. And also lifestyle modifications is very important. Quit cigarette smoking. Avoid illicit drugs because IV drugs users are at high risk of infective endocarditis. Diuretics are only used if indicated. We know diuretics also are teratogenic. What we commonly use is the loop diuretic. Only in failure we are using diuretics. And especially be careful in PIH cases because these patients already have a decreased intravascular volume. And by giving diuretics, you're compounding the problem and the patient may have fetal growth restriction, etc. Infection should be prevented. Avoid exposure to respiratory infections. Vaccinations is very important to all cardiac disease patients. Pneumococcal vaccine should be given, if not all previously given, and the annual influenza vaccine. Luckily, for most of our clinics, we are giving it, and many patients prefer to take it in private. Any cardiac intervention should be done as early as possible. Surgical treatment should be done. Balloon mitral valvotomy should actually be done before the patient conceives, but if it's necessary, it can be done in the second trimester. Use of digoxin only in heart failure and anticoagulation, I'll be dealing with this a little later. It's only done in women with congenital heart disease or artificial mechanic valve prosthesis. Or if there is chronic or recurrent arrhythmias, better to go in for anticoagulation. Now the patient will ask you, when is pregnancy not recommended? In which patients they are not supposed to try for pregnancy at all? That is pulmonary artery hypertension, all these conditions. When the ejection fraction less than 30, severe mitral, all these severe aortic dilatation more than 5 mm, 5 centimeters. Well, all these, you should not be getting pregnant at all. And if the patient gets pregnant, she has to be recommended, she has to be taken to a expert center. What about the high risk groups? The NYHA class 1 and 2 generally tolerate pregnancy well, but 3 and 4, they can land into problems. So they should be under strict medical supervision. Think of early delivery options. When do you admit patients? NYHA 1 and 2, 2 weeks before delivery. 2, we go at 28 to 30 weeks. 3 and 4, immediate ASAP, she has to get admitted. Emergency admission includes any deterioration or symptoms and signs of complications or cardiac failure. How do you plan delivery? You have to have all these patients should be delivered in an institute which is capable of handling her. The mode of delivery is vaginal, definitely, because there is lower risk of bleeding, infection, and thrombotic complications. So, and there is no acute. Suddenly, there's an acute volume shift in cesarean section. The uterus is suddenly emptied, and this is deleterious to the heart. Induction of labor is okay, generally safe, and planned cesarean does not improve maternal or neonatal outcomes compared to planned vaginal delivery. When do you induce labor? Only for obstetric indications. Oxytocin is preferred. Sometimes we also use mechanical dilatation and PGE2 gel. How do you manage first stage? The patient should be in bed, should be propped up or semi-recumbent. Intermittent oxygen, pain management should be there because she will have tachy and it may precipitate heart failure. Cautious use of IV fluids and stop anticoagulation. I'll be coming to that. If any complication, either digitalized, diuretics, derifilin, and also patient should be evaluated repeatedly by anesthetist and cardiologist. Second stage of labor, delivery should be done in the propped up position. Avoid forcing bearing down, avoid Valsalva. Adequate pain relief should be given, and cut short second stage of labor by using episiotomy or forceps. But it's not always needed. Strict cardiovascular monitoring is mandatory. Third stage of labor, you have to manage with AMPSL, active management with oxytocin, but avoid bolus. Give oxytocin, give oxygen, furosemide, and pethidine for the pain relief. Watch for signs and symptoms of cardiac failure because we have lost a few patients, especially after the patient delivers. First, after delivery, keep the patient propped up. Watch for symptoms and signs of pulmonary edema. Now, some patients you have to definitely go in straight away for cesarean delivery. Who are these patients? When there's a dilated aortic root more than 4 centimeters or an aortic aneurysm, you do not allow vaginal delivery in these patients. Acute severe congestive heart failure or a recent myocardial infarction. We know that we are seeing increasing patients who are having myocardial infarction nowadays, severe symptomatic aortic stenosis, or sometimes we have to immediately replace the valve postpartum. It is also better to go in for cesarean section and straight away go in for the cardiac replacement. Sometimes patients who are on warfarin, they go into labor or something like that, we have to deliver them immediately. If that warfarin has not been stopped within 2 weeks of delivery, better to go in for cesarean section because if this patient undergoes normal delivery, she goes in for intracerebral hemorrhage. What are the special considerations? If the patient comes in shock, comes in failure, stabilize the patient before attempting vaginal delivery. And I already told you, position should be semi-recumbent, monitoring, look for signs of failure. Now, what are the conditions that can precipitate heart failure? Obesity is either no, preeclampsia, hemorrhage, and acute anemia. Sepsis and infection can precipitate chronic hypertension with superimposed eclampsia. What about the risk management? Be careful. Do not give excessive fluids. Correct the infection. Aggressive antibiotic therapy is necessary. Thromboembolism and delayed cardiac decompensation. Now, when do we give infective endocarditis prophylaxis? Is when the patient had previous history of that, or if she's having mechanical valves, generally we give the antibiotics. Now, patient is going to ask you before she goes, what about contraception, madam? You first of all, you told me not to get pregnant, but now how do you prevent future pregnancies after delivery? They should avoid unplanned pregnancies. So it's very crucial that we do the guidance properly. Progesterone only contraceptives or IUDs are preferred. Barrier contraception is the best, and you should avoid combined hormone contraceptions in pulmonary hypertension. Sterilization, better to go in for vasectomy. Puerperal tubal ligation can be delayed if cardiac function is unstable. Even last week, we had a patient who was ready for tubal. She had already 5 children, but because we were going to do it actually, but because of her cardiac problems, we could not do it. I hope she doesn't come back to us pregnant again. Follow up is very, very important, and it is necessary that we doctors call the patients back for proper follow up. What about surgically corrected heart disease in pregnancy? Sometimes, as I told you, we are missing heart disease. So, in case a patient needs valve replacement, you do it. Do it before pregnancy, it is very good. But nowadays, what the current concept is, these prosthetic heart valves, if you are using it, they need thrombosis, and they come with their risks in pregnancy. So you have to think about it. Now, these biovalves with porcine valves are becoming popular in the West. Before, we used to give them only to older people. Okay, the advantage is that they do not need the thromboprophylaxis. So nowadays, current studies are going around. You do these biodegradable valves in earlier younger patients after pregnancy, after childbearing, then you replace them with mechanical valves. But still, a lot of study has to go before this becomes a reality. Warfarin, the patient usually will be on warfarin. As soon as she comes to you, change over to low molecular weight or unfractionated heparin. And second trimester, continue it. And then near delivery, more than 36 weeks, switch over back to second trimester, you switch to warfarin. And third trimester, switch back to, first trimester, you have to switch over to warfarin. Second trimester, continue the low molecular weight heparin. And then the last trimester, you have to be very, very careful because of the anticoagulation, which can cause problems in delivery. For labor, you have to stop all anticoagulation 24 to 48 hours before delivery, restart warfarin or whatever it is 6 to 12 hours postpartum or after 24 hours after C-section. Warfarin, low molecular weight, or unfractionated heparin are all safe in breastfeeding. But as I told you, the patient has been on warfarin and she goes to labor, better to go in for cesarean section. Do all cases need antibiotic prophylaxis? No. Only with these conditions that I already told you, history of endocarditis, unrepaired cyanotic heart lesions, artificial heart valves, HOCM, cardiomyopathy, which we're increasingly seeing, especially in our secondary center, or heart transplant. So therefore, meticulous hygiene and infection should be prevented. This is my last slide. It sort of summarizes what all I have said. Look for the predictors of maternal cardiovascular events. You have so many predictors you can do. Advise patients even before conception. And nowadays, there is something called a biomarker, that is NT-proBNP. That is, you do it even before pregnancy. It will predict the problems that can occur when the patient gets pregnant. They also repeating it 20 weeks. It predicts of event later in pregnancy. It seems to be promising. Cardiologists are using it as a guide to monitor and treat their patients. Neonatal events, I already have discussed. And main thing, as we said, do not smoke. Think of all the medications. And also, we have to be careful that babies may be small for gestational age. They may have sudden IUDs, sudden stillbirths, which is known. Thank you.
Thank you so much, ma'am, for this wonderful presentation. We do have some question if you like to take that up.
Yeah.
So, ma'am, the first question is, how should we approach contraceptive counseling for women with significant cardiac risk?
See, contraception, this cardiac risk, I assume that she must be in class 3 or class 4. Okay, so better to avoid pregnancy. Okay, but if she wants how will you advise her? The best thing, as I said, is barrier contraception, or maybe her husband, if you can convince him, she can undergo vasectomy. But sometimes what we do in our hospitals, when they come like this, we stabilize the patients and they come back to us later, we do permanent sterilization. As I already told you, we can use progesterone only pills in these patients, or we can use intrauterine devices. Each patient has to be individualized. You have to take patients on a case-to-case basis, and definitely you have to advise the patient against getting pregnant. And in case she gets pregnant, if she comes for MTP, you must do it within 8 weeks. You're quite safe. Suction evacuation is the best.
Thank you, ma'am. Next up, how do we balance the use of cardiac medications such as beta blockers, ACE inhibitors, and anti-collagen during pregnancy and lactation?
See, now, wait, cholinergic. See, these drugs are usually, we have already a multidisciplinary team. ACE inhibitors are never used in pregnancy because they are teratogenic. Okay. Now, the other drugs, we check with our cardiologists, and with a close multi-systemic monitoring, then only we give drugs. Very few times the obstetrician on our own we start drugs, but every drug we run it through the cardiologist, we run it to the patient's status, and only then we give it. Okay.
Ma'am, one last question. It is, what is the optimal management strategy for a pregnant woman presenting with acute heart failure in the third trimester?
Yeah. Now, see, the main thing is when she's in heart failure means that we may not be in a position at that time to diagnose what problem it is. We have to stabilize her, admit her, put her in propped up position, give her oxygen, slow her heart rate, give her diuretics, digoxin, whatever, along with the physician. First, stabilize the patient and only then think of termination. Whether you do it by vaginally or whether you do it by cesarean section is individualized case to case. But the main thing is stabilize the patient in an intensive care unit. She has to be in a multidisciplinary team, and only then think of termination if necessary.
Thank you so much, ma'am, for answering all our questions. That's all from our audience. Before concluding, ma'am, any take-home message from your end?
Yeah, what I'd like to say is we have come a long way in diagnosing and treating cardiac disease. Main thing is before the patient gets pregnant, any patient with cardiac disease has to see her obstetrician, has to see her cardiologist, and plan properly. If any procedure has to be done, it has to be done preferably before she has conceived. Okay. And because of the advancements, because of the care diagnosing, we are not seeing so many patients in class 3 and class 4 nowadays. When I first started my career, we used to see many patients with very disastrous kind of problems, but nowadays patients are quite stable. We are able to treat them better, and we're able to give them options, and their babies also, and with the early fetal 2D echo, they're not passing on their genes to the babies also. So we have come a long way in treating cardiac disease, but we are not there, but we're almost there.
Thank you so much, ma'am, for taking all our questions and for conducting such wonderful session. It's our pleasure to have you here, ma'am. Thank you so much.
So, thank you, Masrion.
Thank you, ma'am. Thank you.
Okay.